Let's move on to some common skin disorders. Often, questions on step 1 will show you a picture and expect you to identify the disease process. Sometimes you'll be given a picture and asked to choose an answer about its malignant potential. These questions can be quick gimmies if you study these facts. Alright, what are verrucae? They're warts. These are soft, tan, and cauliflower-like. If you look at them under a microscope, they show epidermal hyperplasia, or hyperkeratosis, as well as koilocytosis. Sometimes they're described as looking like church spires. There are many different types of warts, from the most common form, verruca vulgaris, that might appear on the hands, to condyloma acuminatum, which can appear in the anus or on the genitals. Which HPV types cause warts? Most commonly 6 and 11. Do these warts have malignant potential? No. You would expect cervical cancer with HPV 16 and 18. What is this? It's a mole, or a melanocytic nevus. Most of the time, these are benign, but every now and then, a melanoma can originate from a melanocytic nevus. How would you describe an intradermal nevi? It is papular because it is solid and raised. What about a junctional nevi? How would you describe it? As a flat macule. Urticaria is the term used to describe hives, which are in fact wheals that are very itchy. Why are they itchy? Mast cells release inflammatory factors. You can see these with a wide variety of allergic responses. Ephilus is just the technical term for a freckle. It is important to know that freckles actually represent small areas of skin with a normal number of melanocytes, but actually have melanocytes that just produce excess melanin pigment. Atopic dermatitis is an important disease to know. You likely already know that it's more commonly called eczema. Where does eczema present? On the flexors of the extremities, and it itches like crazy. Usually, atopic dermatitis is just one piece of a greater atopic triad. Do you remember the other two symptoms? Allergic rhinitis and asthma. Atopic dermatitis is often compared to a different dermatitis called allergic contact dermatitis. While you would expect atopic dermatitis to come on very quickly since it has some allergic and therefore IgE-mediated signaling, allergic contact dermatitis does not follow the same rule. Here, the skin changes result from a delayed type of hypersensitivity reaction. Do you remember what type of hypersensitivity reaction is delayed onset? It's type 4 hypersensitivity. This is a problem due to contact with an allergen. So what pattern would you expect? You'd expect the lesions to occur at the site of contact. Classic example of this dermatitis is the reaction people naturally have to poison ivy. If a patient comes in claiming to have contacted poison ivy only 30 minutes prior, and they now seemingly have a reaction all over their skin, it's probably not poison ivy, only because it takes a couple of days for the reaction to develop. This is another great example of how questions can be answered on step 1 by knowing the chronology of diseases and the rapidity of onset. What is the name of the molecule in poison ivy that causes a hypersensitivity reaction? Urushiol. Now, the classic lesion psoriasis is multiple salmon-colored plaques with silver scale over them, particularly on the extensor surfaces of the extremity, the knees and the elbows. Do you recall what skin disorder occurs on the flexors? Eczema. Good. In psoriasis, when you look at the skin of these patients with microscopy, there is acanthosis. So which layer is increased? The spinosum layer. There's also parakeratosis, meaning nuclei are retained in the corneum layer, and a smaller granulosum layer. You should definitely memorize these findings, as their presence is usually a pretty big hint that the answer to the question is psoriasis. There are a few diagnostic clues that may help you to confirm the diagnosis of psoriasis in a patient who presents with a rash. The first is Auspitz sign, which means that when scale on the lesion is scraped off, it will spot and tend to bleed. The second clue you might get is that psoriasis is a systemic disease that doesn't only affect the skin. So what else should you look for in patients with psoriasis? Psoriatic arthritis. You can also look for nail pitting, but there can be a whole variety of disease manifestations. Let's talk about psoriasis in a bit more detail now. First, let's do a quick flash quiz. If a patient with psoriasis also has arthritis, what might you expect to see on an x-ray of the hand? Pencil and cup deformity. The final common skin lesion that we'll discuss is seborrheic keratosis. This is a flat, greasy, pigmented skin cell, and it's a tumor, and it includes keratin-filled cysts that happens most commonly in older adults. It's classically described as looking like it's pasted on, but it can't be scraped off, and it really can happen anywhere on the body. Are these lesions malignant? No, not as a single isolated lesion. However, one classic board's question about this skin finding is that it can reveal an underlying disease. Do you recall the sign of Lézard-Trélat? Multiple seborrheic keratoses appear rapidly, indicating an underlying cancer, often of the GI system, and less commonly a lymphoid neoplasm. The next 5 diseases are all types of infectious skin diseases. These are actually very boards relevant, particularly because the first 4 are caused by 1 or 2 bacteria, which can make for difficult diagnoses if you don't try to keep them straight. We'll provide the classical vignette associated with each of these 4. The first is impetigo, which is a very superficial skin infection, usually caused by either Staph aureus or Strep pyogenes. Are you surprised that these organisms cause this disease? Don't be, since they are part of the normal skin flora. It is incredibly infectious. The classic location is on the face, likely on the chin, with some of the lesions rupturing, leaving a honey-colored crust on top. A virtually pathognomonic buzzword for you to remember. Does it scar? No, it's a superficial infection. What bug is most likely the cause of impetigo? Staph aureus. Cellulitis is a very common disease and is probably the start of a spectrum of diseases. Basically, you should think about cellulitis as an acute, painful, red-hot, spreading infection of the dermis and the subcutaneous tissues. The same bugs, Strep pyogenes and Staph aureus, are implicated here. Usually, the patient has a break in the skin from a minor trauma. However, you should be wary of the presenting scenario. For example, what might you expect if the skin is burned? Pseudomonas. So what's on the severe end of the cellulitis spectrum? Necrotizing fasciitis, affectionately abbreviated to neck fash. It's a much deeper injury and is much more serious. What's the bug? Strep pyogenes. But also other flesh-eating anaerobic bacteria can be implicated. The classic description is the finding of crepitus on physical exam, a type of crackling sound, which is quite literally the sound made by rapidly moving bubbles of gas that is formed underneath the skin. This gas comes from the methane and carbon dioxide produced by the underlying infection. The clinical scenario will either include a post-surgical patient or a patient with a skin infection that appears to be worsening very, very rapidly. There may be some blood-filled blisters that form quickly, or a gray discharge from the surgical site. Would you expect these dusky gray edges to be painful? Actually, they're not, because the flesh is dead. And what should he do? Get to an OR immediately in order to clean out the wound. So what's crepitus? It's a crackling sound on exam, which is the sound of moving bubbles beneath the skin. The next skin lesion is actually a syndrome called Staphylococcal scalded skin syndrome. Do you recall this syndrome from the infectious disease chapter? Here, an exotoxin that is released by Staph aureus destroys the attachments between keratinocytes, all within the granulosum layer of the epidermis. Patients develop a generalized erythematous rash with loss of the layers above the granulosum. Classically, this disease is thought to happen in newborns and children. Two things help confirm this diagnosis. First, you should expect that since this is a diffuse disease, there will be some systemic signs, like a fever. The second is that the disease should cover the body almost head to toe and not just be in a focal location, like you would expect if it truly was impetigo, cellulitis, or necrotizing fasciitis. These patients are sick. Does scalded skin syndrome leave scars? Actually, no, it heals completely because it only affects the superficial layers. The final infectious skin disorder that we'll discuss is hairy leukoplakia, which classically appears in the mouth, and even more commonly, only on the side of the tongue. What else would be on your differential for a whitish tongue lesion? Thrush. The clinical distinction is made when you try to scrape it off. Thrush comes off while leukoplakia doesn't, even though it may appear like it should. Do you remember from the micro lecture what virus causes this disease? This lesion occurs as a result of EBV infection. It can also be a sign of underlying immunocompromise, such as HIV/AIDS. Alright, now let's go over the information on blistering skin disorders. The first two we've actually already talked about to some degree when we were discussing the desmosome and the hemidesmosome. IgG antibodies against the desmosome gives which disease? Pemphigus vulgaris. You'll need to be able to distinguish Pemphigus vulgaris from Bullous Pemphigoid. Okay, so Pemphigus vulgaris causes segments of epidermis to lift off away from one another, which leads to the formation of intraepidermal bulli. Do you remember the term for this skin finding? Acantholysis. It can be very severe. On immunofluorescence, you'll see a net-like pattern because the antibodies can be found throughout the epidermal layers, between keratinocytes. Do you remember where the hemidesmosomes are? The basal layer of the epidermis. What might you expect on immunofluorescence of Bullous Pemphigoid? A line instead of a net. This means when the hemidesmosomes are destroyed, the epidermal layer lifts off, and the dermal layer is one untouched piece underneath. On your exam, tense blisters are more likely to indicate Bullous Pemphigoid, whereas flaccid intraepidermal bulli are seen with Pemphigus vulgaris. Also, Nikolsky sign, or easy separation of the skin with gentle stroking, is seen in Pemphigus vulgaris. If the skin doesn't separate with a gentle touch, it's more likely to be Bullous Pemphigoid. Another distinction is that Pemphigus vulgaris will affect the skin and oral mucosa, while Bullous Pemphigoid only affects the skin and will not affect the oral mucosa. So which would you rather, Pemphigus vulgaris or Bullous Pemphigoid? Pemphigus vulgaris is potentially fatal, and your skin sloughs off with a slight touch, so I think that I would go with Bullous Pemphigoid. Let's have a flash quiz. What is Nikolsky sign? It is skin that separates with a gentle application of tension. Ouch! The next blistering skin disease is Dermatitis Herpetiformis. When you think about the word, it quite literally is skin inflammation that appears like a herpes infection. If you look at this under the microscope with immunofluorescence, the appearance is that of IgA at the tip of dermal papillae, which causes the tips of the papillae to light up like snow caps on mountains. The papules and vesicles are itchy and are usually found on the extensor surfaces of the skin. What is this particular skin manifestation associated with? You should think of celiac disease, which in some cases may precede the appearance of GI symptoms. Do you remember what type of hypersensitivity reaction this represents? It's a type 3 hypersensitivity reaction, and it's due to the deposition of IgA immune complexes. The final blistering diseases are erythema multiforme, Steven-Johnsone syndrome, and toxic epidermal necrolysis, which probably shouldn't be thought of as classically blistering diseases. EM and SJS are the two ends of a spectrum that occur as a result of drug reactions, much like the spectrum of cellulitis and necrotizing fasciitis. Toxic epidermal necrolysis is severe SJS that affects greater than 30% of the body. EM is the most benign reaction. EM classically shows a number of different lesions, usually with macules, papules, and vesicles, and some targetoid lesions, which is a classic finding. Many drugs can cause EM, including sulfa drugs, beta-lactams, and phenytoin. Additionally, you may see EM as a result of certain infections, like mycoplasma and HSV. The much less common association made on the board exams. The other even less common possibility is that EM results from cancer or an autoimmune disease. It's worthwhile to know these associations exist, but you should keep EM strongly linked to adverse drug reactions for the purposes of the boards. SJS, in contrast to EM, also has a more concerning skin finding, usually including bullae with necrotic areas, particularly orally, and is found along with systemic signs like fever. What is it called if more than 30% of the skin is involved? TEN. This is life-threatening, and the skin is literally sloughing off. Let's have a flash quiz. What is the common cause of EM, SJS, and TEN? Drug reaction.